Hello everyone. In this video we'll be discussing complex acid-base problems, especially the chronic compensation. Chronic compensation makes the ABG more complex as your baseline bicarb and carbon dioxide levels are not normal. And if you're not careful, you can draw wrong conclusions. In this lecture, we'll examine what kind of challenges do chronic compensation bring us and how to solve them. One of the things that would be logical to ask is that you can simply use the chronic compensation formula in step 3. Why do you need something extra to understand this? And for this, I would suggest that you watch my previous video where we try to use different scenarios to see how using chronic compensation in step 3 can sometimes mislead you. So question number 1, when should you suspect there is a chronic component? And the answer to this is pretty easy. Look at the comorbidities and the medications. For example, patient with COPD, obesity hypoventilation syndrome, CKD, ESRD, patient on diuretics will have some form of chronic component to their ABG. Second, if your clinical picture cannot be explained by the ABG, for example, if you see a patient with diabetic ketoacidosis where you expect your bicarb to be low and this patient has relatively high bicarb, or easiest thing will be if you have previous or recent ABG showing chronic component when the patient was at baseline. Lastly, if your ABG shows high bicarb and PaCO2 for a given pH, you're possibly dealing with a chronic component. So if you look at this various ABGs with same pH of 7.4, the one with a bicarb of 24 and 40 is where normal person sits at. And as you develop more CO2 retention or develop metabolic acidosis or alkalosis, your ratio between bicarb and PaCO2 will change. Mostly it's in the direction of higher PaCO2 and higher bicarbonate, though in patient with CKD and ESRD, you can see lower bicarb and lower carbon dioxide values. Second question is, how do you know where the baseline is? And for this, you have to know some more facts about ABG. There are 3 important ratios that I would like you to remember. First, 0.1 change in pH can happen either from 10 to 12 change of PaCO2 or 5 to 6 change of bicarb. Second, there is 1-to-1 ratio between delta anion gap and delta bicarb whenever you are dealing with anion gap metabolic acidosis. And thirdly, there is 1-to-1 ratio between delta chloride and delta bicarb in patient with non-anion gap metabolic acidosis. You can also look at the recent labs in ABG and observe changes. Chronic changes will persist while acute changes will improve. Lastly, once acute clinical issues are resolved, you can certainly look at the new ABG and that would possibly depict where the patient baseline is. For example, if your patient with COPD comes with altered mental status because of hypercapnia and his pH is 7.2 and PaCO2 is 90, once you treat the COPD, you repeat a ABG and now you get pH 7.38 and PaCO2 of 65. Since pH is close to 7.40, he possibly runs around 65 all the time, so he's a chronic CO2 retainer. Before that, understand how compensation works. For example, if you start retaining carbon dioxide, say your PaCO2 goes from 40 to 50, your pH will drop to 7.3, but your body would like to correct this pH and you will use metabolic means to achieve that. Your kidneys are going to reabsorb more bicarb and you will bring your pH back to near 7.4. One of the things that we understood in the previous lecture is you can never overcompensate. So this will be your new ABG in a patient who is retaining 50 of carbon dioxide. Say for example, you develop metabolic alkalosis because somebody started you on Lasix. Your pH increases to 7.5 and therefore you will compensate it by respiratory means. You will slow down your breathing and you will retain more carbon dioxide and that will bring your pH near to 7.41 again. So this will be your new set of chronic looking ABG where your pH is 7.4, your bicarb is 36 and your PaCO2 is 60. So change of 5 to 6 of bicarb will be equalized by change of 10 to 12 of carbon dioxide levels to attain the same pH. So let's do some examples. You have a 60-year-old obese patient with COPD on 3 liters and comes with weakness and lethargy. These are his vital signs and his ABG shows pH of 7.15, bicarb of 38 and PaCO2 of 90. So there are red flags for chronic compensation. His bicarb and PaCO2 are significantly high for the degree of pH. His BMI is 50. He has history of COPD. So you might be dealing with a patient with chronic compensation. If you solve the ABG using your 5 steps, you will end up diagnosing it as acute respiratory acidosis with some chronic compensation and a non-NAN gap metabolic acidosis. So let's see how to approach this ABG. So start from what you know. This patient is at pH of 7.5, PCO2 of 90 and bicarb of 38. That's your current ABG. And he's possibly compensating at baseline. The only thing we know at baseline is his pH would be 7.4 and there will be some ratio of bicarb and PaCO2 that we don't know. So first thing is to look at the bicarb, and his bicarb is 38. So elevated bicarb can be from acute metabolic alkalosis, and usual causes are either diuretic use or vomiting or severe dehydration. And you don't see any of these things in this patient. So this 38 most likely represents a metabolic compensation for respiratory acidosis. And you know that the acute compensation is pretty small. There is change of 1 of bicarb for every 10 change of PCO2. So bicarb of 38 likely represents a chronic compensation. Possibly it will be slightly lower than this, but we'll stick to 38 and see where we end up. We now know that the change in pH has been caused by PaCO2 change alone, and the drop in pH from 7.4 to 7.15 has to be brought about by change of 25 to 30 of PCO2. So your baseline PCO2 must be around 60. You can also use that formula that we discussed in the previous lecture, that PaCO2 is nothing but 40 times bicarb by 24, and we know that the hydrogen ion concentration at pH of 7.40 is 40. So PaCO2 is around 63, but we'll approximate it down to 60. So that means this patient has two components. The chronic component is the rise in PCO2 from 40 to 60, and an acute component of rise of PCO2 from 60 to 90. So his baseline ABG is pH of 7.4, bicarb of 38, and PCO2 of 60. And now we go ahead and solve this ABG. In step 2, we use 60 because you want to use the normal for this patient at baseline. Normally you would have used 40 because that's what normal for everybody else. So this step tells you that patient has respiratory acidosis. Compensation is pretty interesting to calculate because this patient has two compensation. One is chronic, that means rise from 40 to 60, and other is acute, that is 60 to 90. So his expected bicarb from the first step would be 6 times 2, that is 36, and then acute change will be 1 times 3, that is going to bring it up from 36 to 39. His anion gap is 12, and to calculate the bicarb, as you see the anion gap is 12 and his baseline bicarb should be 38, which is similar to what he's compensating, so there's no other significant acute process going on. So this patient has acute respiratory acidosis and chronic respiratory acidosis with compensatory metabolic alkalosis. So whenever you see a patient with COPD with hypercapnia, use this method to figure out where the patient baseline is. So know that change of 10 to 12 of PCO2 will drop your pH by 0.1. If you do not have ABG, you can look at the bicarb levels when the patient arrived to the hospital, and that would give you some idea because 10 rise in PCO2 would be compensated by 6 rise in bicarb. So it means that if your normal was 24 and 40, increase of PCO2 from 40 to 50 will be compensated by increase of 6 of bicarb, that is from 24 to 30, and so on and so forth. In this example, we have just looked at only one acute acid-base problem. Let's see if we can try to solve combination of 2 or more acute acid-base disorders in chronically compensating patients. So this is another 60-year obese patient, and his pH is 7.05, bicarb is 30, and PCO2 is 90. And again, as we talked before, there are a lot of red flags for chronic compensation. He also seems to have anion gap metabolic acidosis with an anion gap of 24. So again, we start from what we know. Since his anion gap is 24, so delta anion gap is 12, and we know that there is 1-to-1 ratio between delta gap and delta bicarb. So his bicarb of 30 must have fallen from 42. That would account for the 12 change in anion gap. That would also mean that possibly this patient is living at 42 because you don't see any other reason for acute metabolic alkalosis, for example, diuretic use, vomiting, etc. So this patient either has metabolic compensation for chronic respiratory acidosis, and that would be more logical because he has COPD and morbid obesity, or it can also be respiratory compensation for chronic metabolic alkalosis, but we don't see reason for chronic metabolic alkalosis like Lasix use. So in either case, the baseline PaCO2 comes down to be 70. And this we have calculated because change of 6 of bicarb should result from 10 change of PaCO2. If you look at the bicarb, you realize that loss of 6 of bicarb should drop your pH by 0.1. So loss of 12 of bicarb should drop the pH by 0.2. So if you corrected this patient anion gap acidosis, his pH would increase to 7.25. You also know that 12 increase in PaCO2 drops your pH by 0.1. Since he has acutely retained 20 of carbon dioxide, his pH should rise by around 0.16. That means near 7.41. So you have reached a pH of 7.41 where the patient should live if he is chronically compensated. So his baseline ABG looks like pH of 7.40, bicarb of 42, and PaCO2 of 70. And let's try to solve this ABG now using this new information. So first step, it is respiratory acidosis. In compensation, you will compensate from 40 to 70 using chronic compensation and 70 to 90 using acute compensation. And that's bringing you up to 44. Anion gap is 24, so he has got anion gap metabolic acidosis. And to use bicarb gap, we know that for a normal anion gap of 12, his baseline is 42. So for anion gap 24, his bicarb should be 30, and the patient bicarb is 30, so there's no other significant process going on. So this patient has anion gap metabolic acidosis and acute respiratory acidosis. What about triple acid-base disorder? Again, start from what you know and use these 4 ratios to try to bring you up to a logical conclusion. First, know that there's a 1-to-1 ratio between delta gap and delta bicarb in anion gap metabolic acidosis. So that should give you a baseline bicarb if you correct for it. And you can see the corresponding change in pH brought about that metabolic acidosis. And that's change of 5 to 6 of bicarb will change your pH by 0.1. If you know the baseline bicarb, you should be able to calculate your baseline PaCO2 because we know that change of PaCO2 by 10 to 12 is caused by change of bicarb by 5 to 6. Once you know baseline PaCO2, you can compare it with the current PaCO2 to figure out the respiratory component. And you can see the change in pH by the respiratory component by the formula that your change of pH of 0.1 is brought about by change in PaCO2 by 10 to 12. If you end up getting a higher pH, that means there's some additional process going on, that is metabolic alkalosis, which has brought that pH higher. And if you end up reaching a lower pH after correcting for these two, there's an additional metabolic acidosis going on. Remember these 5 facts which can help you analyze the ABG further. 1-to-1 ratio between delta gap and delta bicarb in anion gap acidosis. 1-to-1 ratio between delta chloride and delta bicarb in non-anion gap metabolic acidosis. Change in PaCO2 by 10 to 12 will change your pH by 0.1, and change in bicarb by 5 to 6 will change your pH by 0.1. And understanding that at chronic compensation, the only normal number is your pH, that is 7.4, and your body adjusts PaCO2 and bicarb to achieve it. Make sure that everything fits together. So steps to reading any ABG: look at your patient, try to find a differential, and then order ABG and then read it. Check the integrity of ABG using the Henderson-Hasselbalch equation. Next, ask if there is a chronic compensation, and if you see chronic compensation, find the baseline ABG and use it to find the primary process in step 2 and expected compensation in step 3 using these 5 steps. Suspect chronic compensation if the clinical picture doesn't match his ABG, patient has underlying chronic conditions, and patient has too high PaCO2 or too high bicarb for a given pH. And know the ratios. Know that step 4 of an anion gap can be looked at independently of all other 5 steps. And always try to put everything into clinical context and see if everything fits. So take it easy. ABGs can be a little complicated, but in exam you will not be typically asked about these very complicated acid-base problem with chronic compensation. However, you will encounter them quite often in real life scenarios. So follow the 5 steps and understand those 5 principles that we have discussed to help your patients further. Thank you.